Well, good afternoon, everybody. Thank you for joining us for our first edition in the MEDtalks series. We are delighted to have Dr. Craig Canapari join us. This is a sleep training boot camp with Dr. Canapari this afternoon. It'll be for approximately around 30 minutes, just some housekeeping items to run through. We'll do about a 20-minute presentation, and then we're going to open it up for questions. If people have any questions, Dr. Canapari will stay on after his presentation to answer those questions. You will be able to see in the top right-hand corner, if you do have some issues, there is, with some audio problems, you can call that toll-free number and put in that access code, and it will allow you to get audio that way. Also, just a reminder to those joining us, we will also be recording this webinar and make it available to your HR department. So if you want to have access to this later on, they will have a link that will allow you to see that. With all that being said, once again, thank you for joining us. Dr. Canapari is a pediatrician at Yale New Haven Children's Hospital in Connecticut. He is a specialist in the care of children with breathing and sleep problems, board certified in pediatrics, pediatric pulmonology, and sleep medicine. He studied at University of Connecticut and did both his residency and fellowship at Mass General Hospital. And I like to say he's one of the nicest guys in medicine, very personable, and looking forward to hearing his presentation. Dr. Canapari, I'll open it up for you to take it from here.
Terrific. Thank you very much for your kind introduction, Andre. Can you guys hear me okay?
Yep, we're good to go.
Terrific. Okay. So I thought that today we would talk a little bit about sleep problems and sleep training in kids. Now, forgive me, we're going to go from infancy through the teenage years, and I realize people here may have a child in one of those groups but not the other. But if your children are little, they will be teenagers one day. So here we go. I just want to give a brief overview of problems falling asleep during childhood and adolescence, and we'll talk about specific strategies for addressing them. We'll start by talking about the evolution of sleep in childhood, and then talk about insomnia in younger children, both causes and treatment, and then insomnia in older children and teenagers. So, anyone who's a parent knows that children change a lot, especially in the first year of life, and this is definitely true in the arena of sleep as well as in everything else. Infants have a quite variable amount of sleep that they get when you compare one child to the next. That's why the average sleep duration in infants ranges from 14 to 20 hours in a 24-hour period. Now, I was one of those babies who slept for 20 hours. My mom was always bringing me to the doctor's office just worrying there's something wrong with me. On the flip side, you have those children who are sleeping for 14 hours a day. I can guarantee you that they are generally not sleeping for 14 uninterrupted hours at night, and their parents are usually pretty stressed as well. Once children move into the preschool age group, from early toddlerhood at age 1 through age 5, the typical sleep duration becomes usually around 13 hours of sleep, but 12 to 14 is a normal range. Children in the first 2 years of life will usually take 2 to 3 naps a day. Up until age 2 years, then they'll take 1 nap and then get the rest of the sleep at night. When children enter kindergarten, by that time they usually have given up napping, and if they are still napping in kindergarten or later, it does imply that they're either getting not enough sleep or there's a problem with their sleep at night. And then we move into the teenage years, where teenagers need really between 8 and 9.5 hours of sleep at night. Unfortunately, very few of them are getting it, and we'll talk about some of the reasons why. So let's talk about problems falling asleep. Now, I'm going to give you just a little bit of information about the biology behind sleep, because it's important to understand what happens when things go awry. So, it's important to note, first of all, that it's normal to wake up during the night. This is what's called a hypnogram, and all that means is it is a roadmap from when you go to sleep here throughout the night. Say a child without any sleep difficulties, they fall asleep on their own, they have a sustained period of deep sleep in the first few hours of the night. This is when your child falls asleep in their car seat. You can pick them up, put them into bed, and they don't even wake up. During the night, around 2 or 3 hours in, they have the first period of REM, which is highlighted here in red. Now note that REM sleep or dream sleep is pretty light sleep. If you wake up from a dream, you're lucid, conversational, you feel pretty wide awake. And it's very common to have brief awakenings during dream sleep. You don't remember them the next day unless you're awake for 5 minutes or more. Now, why does this matter? Well, my boys are going to be 7 and 4 this month. And I remember when we brought our first son home from the hospital, they tell you, don't just console your baby whenever they cry. Don't worry about it. They can't soothe themselves. So you can rock them to sleep, nurse them to sleep, swaddle them tightly. Infants can't really soothe themselves. But a couple of things happen between ages 4 and 6 months. The first thing that happens is babies evolve the ability to soothe themselves. So they don't have those long periods of sustained crying and fussiness that you experience in the first month or 2 of life. The other thing that happens is that they realize when you're not there. And this is where things come into trouble, where parents start to get into trouble when they have a child at 4 or 5 months who's been sleeping really well at night and starts to wake up again. What has happened is that their child has never really learned to put themselves to sleep. So contrast this with our prior diagram. We have a little girl who falls asleep with mom or dad rubbing her back. She still falls into a deep sleep. Her parents relax, they do some laundry, they watch TV, they get into bed, and around 10:30, just as their eyes are closing, they just hear that cry. And they know they're not going to have a good night. And every time this child goes through a REM period, and this can happen as frequently as every hour and a half to 2 hours after the first REM period, which happens maybe 11 or 12 at night, that child can wake up and need mom or dad to go back in and do what they were doing before when she went back to sleep. This is called inappropriate sleep-onset association disorder. It's the classic behavioral sleep disorder of early childhood. Now contrast that with a child that's a little bit older, a kid that has transitioned from a crib to a bed, typically between ages 2 and 4. All of a sudden, what's different is these kids can follow you out of the room when you leave at night. In children with limit-setting behavioral insomnia, bedtime is prolonged. It can be a knockdown, drag-out fight every night. It can take an hour, and it usually is not that pleasant. When we say this is characterized by curtain calls, what we mean is you leave the room and you hear that little pitter-patter of feet coming out of the room 5 minutes later asking for, can I have another glass of water? Can you give me one more hug? I want another story. Rub my back. Can I go to the bathroom again? I know I went to the bathroom 5 minutes ago. And one other thing I want to mention in passing that in younger kids and older kids that can disrupt sleep is nocturnal feedings. Usually an issue for older kids, but it can also happen with younger kids. This is just showing at kids around 5 months of age when they feed. Typically, the kids 5 or 6 months of age should not need any calories at night, but if they're regularly nursing or taking bottles at night, they have learned hunger at night. Just like you or I might get hungry around dinner time, they get hungry in the middle of the night. That's another thing that needs to be addressed if you would like your child to fall asleep and stay asleep during the night. Now, what are the strategies that parents use to help their children, can use to help their children fall asleep without parental involvement and stay asleep for the night? Well, let's talk about extinction. Nobody likes using the term extinction. We're not talking about your child going extinct. What it means is ignoring a behavior that you would like to go away. Unmodified extinction means putting your child to bed, closing the door, putting on some headphones, pouring a glass of wine, and just ignoring them for the rest of the night. It's very effective, but most parents really can't tolerate this because there's a significant amount of crying that goes along with it. Graduated extinction was the method popularized by Dr. Ferber, and it is extinction where you are checking in your child at specified intervals during the night to reassure them that you're still there and reassure you that they're okay. Extinction with parental presence. Some people have to do this if they share a room with their child. It means ignoring their child while they're fussing and crying, but being in the room. Camping out is another method that's been proven in research to be effective. This is a sort of a kinder, gentler way of sleep training, and it's gradually withdrawing your presence from your child's room at night. So if you're rubbing your child's back to have her go to sleep, then you're standing by the bed for a couple of nights without, without touching her. Then you're sitting in a chair a little bit away from the bed, and you're sitting in a chair near the door, and then you're sitting in the hall outside the room. This can be effective, but some parents find once they get far enough from the bed, their kid will pop their head up out of the crib, look at them, and sort of as if to indicate, what are you doing? And then they may have to switch to an extinction-based protocol. I just want to note in passing, too, that even if there is some fussing associated with sleep training, there's no evidence that it causes any lasting harm to children, and there's good research to support this. Now, I find that bedtime modifications are often the things that have been missing when parents have tried and failed to sleep train in the past. Positive bedtime routines mean simply having a positive, goal-directed, and relatively brief bedtime in the evening that's enjoyable for everybody. If bedtime is disjointed, if you're taking your child upstairs to brush their teeth and they're coming up downstairs, going outside, watching TV, going to their room, going to their sister's room, going back to their room, it's not going to work. Bedtime fading, I feel like, is the secret sauce we use in sleep clinic to sometimes help people succeed. This essentially means having your child go to bed earlier for a set period of time. Sorry, I misspoke. Go to bed later for a set period of time with the idea that if your child is significantly tireder, they will have a much easier time learning to fall asleep on their own, and then you can move their bedtime earlier over the next couple of days once they've successfully fallen asleep on their own. The bedtime pass is the method that's good for limit-setting disorders. This means giving your child a hall pass and allowing them to come out of the room one time only for some parental attention. And reinforcement or sticker charts can be somewhat helpful, but not as effective in other behavioral domains like, say, potty training. Now, for the parents of children who are on the autism spectrum or children with special needs, visual schedules can be very helpful. There is information on this on the Autism Speaks website. They have a parent toolkit for putting these together. For children that can read, a checklist that they use every night can be very helpful. For children that don't read, using a pictorial schedule, either with cartoons like this, or even making one with pictures of the child's own pajamas, bedroom, etc., can be very helpful in providing a predictable roadmap for children who are struggling with sleep onset and maybe on the autism spectrum. So, it's time to talk about some other disorders that occur in older children and teenagers. I wanted to mention restless leg syndrome because this is an underdiagnosed problem in children. And it's comprised of leg discomfort that happens at the time of sleep onset, interferes with falling asleep, and is relieved by movement. This is from the Restless Leg Syndrome Foundation website. This is a 13-year-old girl. She says that I feel like I need to stretch my legs. My drawing is showing me being stretched up by ropes because I feel like I know to stretch my legs whenever I go to bed or if it's late. This condition is easily treatable with either iron therapy, medication, and also some behavioral modifications as well, and it's important to identify it. It does overlap somewhat with growing pains as well. And finally, I want to talk about teenagers, because teenagers structurally have some degree of sleep disorder built into their lives, unfortunately. We'll talk about why, and some teens that can get really out of control. Now, this is the vicious cycle of adolescent sleep. We're going to start with a child going to bed too late. Maybe they have too much homework. Maybe they're up playing their Xbox, etc. They get short sleep during the school week, partly a function of early school start times. They're sleepy during the day. They might take in caffeine or nap in the afternoon. I see that one of the questions is about power napping. Usually napping for 10 or 20 minutes is okay, but if you're napping for 2 to 3 hours, it's going to interfere with sleep onset. Catch-up sleep on the weekends, kids sleeping in for the whole morning and into the afternoon is counterproductive as well because they have difficulty falling asleep on Sunday night, and it can perpetuate this cycle. Now, this is pertinent to both little kids and, but even more big kids, teenagers, and adults. To understand why you fall asleep at night, there's two factors at play. One is your sleep drive. The longer you're awake, the more sleep drive you have until you fall asleep and it drops off after you fall asleep. Then there's a wakefulness drive, commonly referred to as a circadian or body clock. This provides it allows you to stay awake in the late afternoon and evening without falling asleep. Now, when teenagers enter adolescence, their body clock shifts later, even as school start times are moving earlier, so they have some sleep curtailment built into it. Some teenagers have a problem called delayed sleep phase syndrome, where their circadian clock is bumped even later, and they essentially cannot fall asleep till 2, 3, 4 in the morning. On school vacation, like summertime right now, they may actually flip-flop their days and nights, and this is important to identify and address. And you really have to ask some pointed questions of your teenager, because parents don't always know when their teenager is falling asleep. What can you do to adjust body clocks in adults and older kids? If you want to move it earlier, morning light exposure, taking blinds out of your teenager's room is helpful. Exercise in the morning, a little bit of melatonin, actually a small dose a few hours before bedtime is helpful. Moving the schedule later, puberty does this. Evening light exposure, think tablets, computers, TVs, smartphones, etc. And evening exercise, move things later. And I just want to talk a little bit about psychophysiologic insomnia, which starts in the second decade. These are people who are really afraid about falling asleep. If you ever had the sensation of feeling very anxious about falling asleep, that is a problem that happens for you. You're worrying about it every night, and the worry is keeping you awake. That is psychophysiologic insomnia. We can address this via shortening time in bed, adjusting how people use the bed. I really try to avoid medications because behavioral therapy is effective and produces more lasting change. Certainly something that we could do, over the phone or in a consultation. I will say, going forward, no matter the age of your child, if your child is school age, it's important to think about how do you get them to re-enter the school year if their school schedule is not if their sleep schedule is not where they're going to need it to be when they go back to school. One thing you can do is adjusting light exposure. Again, taking those blinds out of the room, having them wide awake. Of course, don't take the blinds out of the room of your little kids, otherwise they're going to be up at sunrise. Moving bedtimes and wake times earlier by 15 minutes every day or two for kids that are sleeping in later than they're going to need to. That's about as fast as you can go. And I would say start now, because you have a couple of weeks to work on this, lay the groundwork for your child to have success when they enter school. In terms of next steps, I'm going to take questions now. I want to mention in passing, I have a website. I'm sorry the name isn't that original, on just topic sleep problems in kids, little kids up to the teenage years. I'm also available through 2nd.MD for consultation on sleep or breathing problems if you need further assistance. And at this point, I would like to actually go through some of the questions you guys have provided here. So let me just go right through. So Karen has a question, any tips for effective napping? I'd say that for children who are in the first year of life, usually the first nap will come a couple of hours after they wake up, so fairly early in the morning. The second nap usually is right after lunch. It captures that sort of bottoming out of the circadian drive that occurs after eating, and you want to apply the same principles you do to napping that you do to when a child is going to sleep at night, and ideally having them go to sleep on their own. Now, hold on here, and I'm just going to look at a question from Alan here about power naps, taking 10 to 20 minute naps during the day. It certainly can be very refreshing. On the flip side, my wife is unable to take a power nap. It's irritating she takes a less than 3-hour nap. How can you start power naps? It's a good question. I mean, Ellen, I'm kind of with you that I think taking a shorter nap is more effective. I wonder if in your wife's situation that perhaps there's actually some issue with her sleep at night that is making her so tired during the day, because ideally, getting high quality sleep at night and very brief naps during the day to refresh you is ideal, and someone who is getting a normal amount of sleep at night and still requiring a 3-hour nap during the day to feel refreshed, it is worth inquiring a little bit as to what the issue may be with the sleep at night. The final thing is 3 hours means she's likely getting through deep sleep and then light sleep and waking feeling better. So now I see a question from Karen about sleep apnea in children versus adults. This is a topic dear to my heart because I run our pediatric sleep laboratory here. Sleep apnea is a condition where people have obstruction of their upper airway, meaning that it narrows periodically during the night. So that part of it is the same in kids versus adults. What's different in kids are two things. First of all, children are much less likely to have upper airway obstruction than adults, even though their airways are smaller. So children that snore, have pauses in their breathing, or irritable or attentional problems during the day may have obstructive sleep apnea, which the best way to diagnose is through an overnight sleep test. The most significant difference, however, is in treatment. Younger children commonly will benefit from having their tonsils and adenoids taken out, and also therapy for any sort of environmental allergies that they have. Adults more commonly will require continuous positive airway pressure or a CPAP mask. Let's see. Here's another question. My 6-year-old still wants to nap. Any advice to have her transition out of this habit to get her ready for first grade? I think that's a terrific question. And the first step in here is really carefully assessing how long your child is sleeping at night. For a 6-year-old, the range of sleep your child may need may be anywhere from 11 to 14 hours of sleep at night, maybe a little bit less at age 6. Is your child having any difficulty falling asleep? In the morning, is your child wide awake, or do you need to get up your child at school time? I can tell you a typical 6-year-old, as the proud owner of one, he's usually getting me out of bed in the morning. So if your child is going to bed at, say, 8 o'clock at night and sleeping till, let me back up a little bit. The typical sleep duration is probably more like 10 to 12 hours. So if your child is falling asleep at 8 o'clock and you need to get her up at 8 in the morning, then you want to think about, is there a problem with sleep during the night? Is she in fact having difficulty falling asleep that you're not aware of? Is she waking up during the night? Is she having significant snoring, which could be associated with sleep apnea and fragmentation of sleep, leading to lower quality sleep and increased sleep drive during the day? Alternatively, some children really do just need a little bit more sleep than their peers. So if the questions all that are she's getting enough sleep at night, she's well rested in the morning, and she just needs a little bit of a nap, it's not ideal, but I would take a careful look and make sure there's no problem with her sleep. Can you let your child read past bedtime to help her get sleepy? I think this is a follow-up question. One thing that is clear from looking at older children and adults that it's probably better to not do activities in bed if you're having problems falling asleep. So if your child needs to read a while before she's sleepy, it might be better for her to do it in a chair in her room than get into bed when it's bedtime. If this is in reference to the 6-year-old, then we have to take a harder look at why is she not sleepy during the day? And if she is napping in the afternoon, that actually is reducing her sleep drive at bedtime. So Lori, if you wanted to say how much your child is napping during the day, you may want to curtail that afternoon nap a little bit, or alternatively move it earlier so she's still tired at bedtime. The problem with, and coming back to the napping question for older children and adults, the problem with long naps is it reduces your sleep drive, and you may not actually get deep, high-quality sleep during the nap, so it leads to a reduction in high-quality nocturnal sleep. So, if she's having a prolonged nap during the day, she may not be getting the benefits of getting that sleep during the night. So I'm just trying to think of other topics that maybe worth addressing here that we get a chance to talk about. Again, I just want. Sorry.
I was going to say, Doctor, there's one interesting question there. I'm just reading from Kathy Pence. It looks like. You see that one there?
Oh no, I didn't. Sorry, I didn't. Yeah.
We just got a couple more questions in, so we just got a chance. Great.
So let's see. We have a 6-month-old who only recently started sleeping through the night. Next month, we'll travel to visit family on the East Coast. We're in the Pacific time zone. What advice can you share about moving this 3-hour time change and how to keep the positive night sleeping trend? Or should we expect a bit of regression when we go back home? So congratulations on your child, and I think it's terrific that you've gotten your child to sleep through the night. You have allowed yourself a significant period for your child to get used to their new schedule. That being said, you'll find as parents, when you travel with your child, there is certainly bound to be some degree of sleep disruption when you travel, especially across time zones. Though I will say I was surprised when we traveled with our 6-month-old from Boston to England how rapidly he adapted. So a couple of thoughts. One is, if you can preserve your home schedule on your trip, and that works for your family, and if you're staying with other people, there's no, that is totally fine to keep your child on the Pacific time zone schedule. That being said, I do find that children in the first year of life are quite sensitive to light exposures. So, you may take a couple of days to adapt. Your baby may adapt very rapidly to the changing light patterns on the East Coast. And then what I would anticipate when you come back is that your child, in terms of regression, may be going to bed earlier and getting up earlier than you like. And the way to address that is to just sort of try to keep them up and put them on the regular schedule when you come back. The other thing is, I wouldn't be surprised if there are some breakthrough nocturnal awakenings after the trip, and don't feel totally discouraged by that. It's pretty normal. There are going to be other times when your child gets a cold or something else happens, and things get a little bit disrupted. If you've achieved good sleep once, you'll achieve it again. Now, the next question is, how does your diet affect sleep? This is this is an interesting topic. I would say that diet can affect sleep in a couple of ways. First of all, caffeine or stimulant intake in teenagers can be a significant issue. Although my 7-year-old keeps asking me why he can't have Coca-Cola, since I value the fact that he goes to bed at 8:30, I don't let him have it. In terms of other nutritional factors, certainly if you have lactose intolerance or celiac or something like that, can be associated with disrupted sleep. I will say that I have seen some rare cases, and this is described in the literature, of children without lactose intolerance who do seem to have a significant degree of sleep disruption associated with milk intake. I can't explain it from a physiologic standpoint, but I've had a few patients that do get better when we withdraw milk from the diet. Next question is, what is the minimum healthy amount of sleep that one could sustain for a long period of time? I think this is an individual. The answer to this is pretty individual because everybody needs a different amount of sleep. But Saul, if I'm being a little bit slippery here, it's because it's a difficult question to answer. In a perfect world, meaning you're getting enough sleep, you go to bed when you're tired, and you wake up in the morning, and you don't need an alarm clock because you're so well rested. That doesn't describe my lifestyle, and it may not describe yours as well. It is fairly clear that for most adults, if you're getting less than 7 hours of sleep at night, consistently, you may have some problems with attention, with vigilance, and there are also, believe it or not, effects on weight. There's increased appetite and increased weight gain associated with sleep curtailment, and also increased inflammation in the body. So, it's hard for people who are driven, successful people sometimes to get enough sleep at night. I mean, I'm a night owl, and my kids are morning people, and I'm not perfect about this as well. But I'd say that the ideal amount of sleep is the one where you're well rested in the morning and not tired during the day. What the minimum is, honestly, for me, it's probably about 7 hours a night. If I get 7 hours a night, I feel pretty good. I think it varies a little bit from person to person, but I say if you're getting less than 6 hours of sleep at night, you could be anticipating having some significant health consequences.
Dr. Roll,
does the quality of sleep have a direct effect?
Sorry, Doctor, I was going to jump back in there. You've hit a myriad of topics. I really appreciate it. I know you've got to run off back into clinic, so I don't want to hold you up unless you want to hit another question.
Sure, I can just cover these last two. That's no problem.
Okay, great.
A quality of sleep on direct effect skin, hair, or eyesight. I say I don't know the answer. I will say that there does seem to be some effect on people's looks in terms of, bags under their eyes, etc. Hair, I'm not sure, but I do think, my mother will tell me when I don't look well rested. She can tell, and other people can probably tell as well. And finally, how effective are prescriptions such as Lunesta as a sleep agent? How long should take one sleep agents such as Lunesta? I mean, these agents are generally fairly effective, but I think the problem is the effect goes away when you stop taking them. Some people with insomnia too will develop some degree of tolerance to them, and you need to rotate medications over time. Cognitive behavioral therapy, working with a therapist, certainly can help. And there are modules online as well. For look up CBT or cognitive behavioral therapy for insomnia. It's been shown to be as effective as medication and produce more lasting change. So I think it is potentially valuable as well. So I use medications in my patients when I have to, but I always prefer to teach them and their families how to have effective sleep without any pharmaceutical aids. So okay, I think we've covered the time. These are great questions, guys. I hope this was useful to you, and perhaps we'll have some consultations from you in the future. I'd be happy to talk to you about your children's sleep issues.
Thanks, Dr. Canapari. I really appreciate you taking time today and valuable insights. Actually, having a couple of young children myself, learned a lot. Everyone, as Dr. Canapari just mentioned, if you have the need for a consult with Dr. Canapari, please contact us. Please remember it's free for you to use 2nd.MD as a benefit. So jump in, submit a question, and we can get you directed through to Dr. Canapari. That concludes the talk. Thank you very much. Dr. Canapari, I'll be in touch with you shortly. And we look forward to hosting the next Med Talk in about a month or so. Thank you, everybody. Bye-bye.
Terrific. Take care.